What is up, good people? My name is Haney Malamat, and I'm joined by Adam Green. What is up, my man? Oh, I can't hear you. Let me see. It says guest has muted themselves. Why would you do such a thing? Oh, you know what it is? Nope. Give it a try now. I cannot hear you, Adam Green. So I'll vamp for a little bit until we figure out this muting issue. My name is Haney. That's Adam. We run the Critical Care Lounge. And this episode is a two-parter. We've never had a secondary episode where we've had guests back. And this is the Pills That Kill Part 2. These two guests that we have on for you are back by popular demand. These people were wanted by all of you. So please, in the chat, let me know where you're writing in from while we get Adam's audio sorted. And don't forget to like and subscribe to the video. Let me see. Adam says I have him muted, which in real life is probably true, but in the podcast like this, we don't want that to happen. Give me a sec. Adam, say something. You're still muted. Yeah, go ahead and log off and log back on, and then this will work, everybody. So I'm going to monitor the chat this entire time. So please, like I said, let me know where you're from. Let's see if Adam's in here. Adam, my man, are you there?
I'm here.
There he is. Oh, the tones of Adam Green. Good to hear you, my man.
How are you?
Good. How have you been?
Good. I had this big story, which I was going to tell right now. And then I realized it's not a good story, but now I'm committed. I'm going to tell you anyway.
That's like the best joke ever. Anyway, what about this weather we're having? Go ahead, man. What do you got?
So I went to get a salad, and then they said, "Hey, have you got your vaccine yet?" And I said, "I've gotten vaccines before." And then next thing I knew, I sat down, and in 5 minutes, I had COVID in one, flu in the other, and my TB screening done.
Boom. I thought you were going to do smallpox.
That's it.
Monkeypox too.
Yeah, no, next month. Next month.
What happens when you run out of extremities, but there are 5 vaccines? What do you do?
Well, I asked him, I said, "Can you just put one in both arms?" And he said, "I'd prefer not." And I just never knew that he would have a preference as to where my vaccines are.
You went bilateral then?
I went bilateral, yeah.
Which side is hurting more now that you have both to compare to? I'm curious.
I think so. The flu shot was a stronger pain.
Okay.
And the COVID was just a little bit slight pain, like a little more sharper. But my right arm, which is where the COVID was, definitely it's a little heavier than my left.
Okay.
Right now.
Well, we will closely monitor the situation as the hours and weeks go on. But we have 2 guests waiting. 2 guests who are back by popular demand. As I was telling everybody, I think this is the only time we've ever had a 2-part series, and it's only because all of you have requested these 2 guests, right? So Before I bring them on, let's just go ahead and roll the intro. What are we talking about today? That took me 3 days to do, Adam.
It was amazing. It was like life-changing, actually.
I appreciate that. Yeah, we just got 50,000 new subscribers because of that video. So, thank you. Adam, who do we have on today, or whom? Is it whom? Who do we got on the show?
So, same too. Do you want to pull them in? So we have Matt Saltzman, our ED toxicologist, right there in the middle, and then none other than critical care pharmacist Firth. How are you guys doing? Locked and loaded.
Great. How are you doing?
Great. Glad to be back.
Thank you for coming. Yeah. Thank you for coming.
Thanks for having me.
Yeah. So we're basically going to ask the exact same questions as last time. It's going to be the exact same show. We're just going to try to do a little bit better this time.
Are we going to start with methylene blue again?
That's
good,
right.
I totally don't know anything else.
Good. So, Haney, what are we talking about? I guess just toxicology.
Yeah, toxicology TBD. No, TBC. To be continued. What do the kids say? Whatever. It's part 2.
So we left off last time. We had a 3rd case, and we kind of spilled the beans last time. So it was going to be Tylenol, and I thought we'd expand on that. So really, the entire show is going to be, and we'll see where it goes. Is going to be about Tylenol, Tylenol overdose, how we approach it. I'm really interested to hear both your perspectives, and then we'll probably go into a little bit of a spiral and just into acute liver failure in general, and we'll go from there. Okay. Cool.
Sounds
So let me read the case, and then Haney, you want to jump in with the first question? So, 62-year-old guy, and I always write this in my consult notes, is with many comorbidities. That means those are all the abbreviations I don't care about that everyone lists forever and ever and ever. In fact, I said here 60 with many comorbidities not worth discussing, including chronic back pain, previously managed with acetaminophen, comes in with jaundice, confusion, nausea, vomiting. His family then tells you that he was recently prescribed Percocet for his back pain, which he takes every 4 hours, and has started taking some NyQuil for insomnia. So I liked this case because it's not always that dramatic. I took, the entire bottle of Tylenol because I'm broke up with my boyfriend. Sometimes it comes in like this. So I don't know, Matt. Why don't you tell me? You get all those toxicology phone calls. How did these Tylenol cases really present? What are the kind of variety you hear about?
Yeah, I think, the case that you're presenting, Adam, is probably less common, but one that we're more likely to miss in the emergency department, right? Because this guy could have many reasons for having an acute hepatitis, acetaminophen being one of them. We certainly do see this single acute, sometimes massive ingestion. Um, and then we see the chronic ingestion, and every now and then we pick up a case where it's a patient who comes in, let's say they're having dental pain, and they say they're taking ibuprofen, and you ask them, how much are you taking, and they say, oh, I'm taking 2 500 milligram tablets like every hour, and I've been doing that for 2 days. And you say, wait a minute, ibuprofen's not available as a 500 milligram tablet, so what have you actually been taking? And that's really concerning, right? And so, acute on chronic and chronic, um, and again, the case that you're presenting is one that we could miss or easily attribute to something that's not acetaminophen induced. But that's why the history becomes so important, right?
So,
The combination of acetaminophen plus oxycodone is Percocet plus, nighttime sleep aid, which often has acetaminophen in it, and then a whole bunch of over-the-counter medications, and that's why, we screen routinely.
yeah, I love that you said 500 milligrams and mentioned ibuprofen. Is that when I think about ibuprofen, I know the dose is like 800 milligrams, but like Firth, if I were to ask you if you had a little bit of pain, like how many do you actually take? Because I take like one or two, maybe. I would never take 800 milligrams. So you go 800. You're a big.
I'm usually 400 or 600, depending on what I'm treating. So if it's pain, I'll probably do 600. If it's a little headache, 400. If it's a fever, I'm probably going right for 800 because I need probably at least 1,200 milligrams for an antipyretic effect for the day.
Yeah.
So I want to get there quick. So it depends on what I'm treating. So I'm probably not the right person to ask.
Yeah,
The most people should probably take 200 to 400 milligrams at the most if it's over the counter.
So the question I was going to get to is how much Tylenol is too much then? Since we're talking about acetaminophen, when do you hear that you think too much? Is it a 24-hour period or?
I think 10 to 12 grams per day is what kind of stands out in my mind for an acute overdose, or more than 200 milligrams per kilogram of ideal body weight is the numbers that kind of stick out to me.
Yeah, a bunch of years ago, the FDA was looking at, total daily dose of acetaminophen, and they drew the cutoff at 3 grams a day. But I think for most people, if you were talking about, I think, a therapeutic dose of like 15 milligrams per kilogram, every 4 hours, you're going to be above 3 grams. But still, the FDA made that cutoff of 3 grams maximum therapeutic dose per day, right?
Let me ask you this before. This is just a random question, but these are things that always come up for people who we have in the ICU. Sometimes they have cirrhosis, and people are like, "Well, I don't want." They have a fever. I'd like to give them Tylenol, but they have cirrhosis. Is that let's just play devil's advocate? Is 4 grams a day for someone with cirrhosis too much, or are you still well below the toxic threshold? Firth, why don't you?
So I would say that it's definitely too much. I think the most recent recommendations for someone with liver impairment would be up to 2 grams per day. So 4 grams probably would start creeping into toxic levels, which I think we're going to talk about probably in a little bit.
Gotcha. Okay, great. So let me ask you this question then. And first, I'll throw this to you. Can you explain this alcohol Tylenol syndrome? More of the pharmacology behind it. A lot of people who are co-ingesting for overdose will take it and make things worse. But just let's start off with the basis for that.
Sure. So unfortunately, before I can get into that, I kind of got to talk a little bit about what happens during Tylenol toxicity and kind of how Tylenol is broken down. So I know last episode I almost got thrown off for talking about the Cori cycle, so I'm going to keep it a little simple today.
By the way, the Krebs cycle also counts to get you thrown off.
I'm not going there. We are going to go to the liver though. So basically, when someone's taking Tylenol and everything's working the way it's supposed to, Tylenol is broken down primarily by the liver. 95%. For the most part, 5% gets excreted renally, basically unchanged. But in that 95% that's liver metabolized, about the majority of that, 90% of that is done by glucuronidation. And it breaks it down into something that's non-toxic. Unfortunately, the rest of it that's broken down is done by the cytochrome system, the P450 system, and specifically the 2E1 pathway is responsible for breaking down Tylenol into, unfortunately, a toxic metabolite. Now, in normal circumstances at therapeutic levels or less than therapeutic levels, we have glutathione stores in the liver that are responsible then that break down that toxic metabolite. So in normal circumstances, there's no issue. Now, when you start introducing things like alcoholism, and we have to differentiate acute versus chronic. So in chronic alcoholism, unfortunately, a lot of their glutathione stores are already reduced due to their chronic habit. So they're putting themselves at higher risk for the toxicity since they don't have those glutathione stores to break down the Tylenol. The one thing they do have going for them is that the 2E1 pathway is impaired because of their abuse. So that might not be able to break down the toxic metabolite or cause the toxic metabolite quite as often. Interestingly, though, with acute intoxication, so patients with no history of, say, alcoholism or cirrhosis, an acute binge for someone who's trying to overdose on Tylenol and wash it down with their alcohol, the 2E1 pathway is inhibited to the point where it actually has been shown to be protective for these patients because it's not able to actually convert the Tylenol into its toxic metabolite. So there actually have been some case reports and some studies that show that those patients actually have better outcomes than patients that overdose on Tylenol without binging and with alcohol.
Whoa.
2E pathway. Got
Whoa.
it.
2E1, yeah.
2E1.
All I heard is take less Tylenol if you drink too much.
Or you can drink a lot and then take a lot of Tylenol.
Yeah, this is not an endorsement for washing down your Tylenol with your alcohol. But yes, it does actually have some protective properties.
Okay, good to know.
Awesome.
Matt, did you have anything else to add to that?
No, I'm waiting to touch on the urea cycle later in the show, though. So stay tuned, because I want to talk about oxyprolinuric acid and impact on the urea cycle and hyperammonemia. So
let's get to that hyperammonemia.
Matt, I think we covered
up first.
I think we covered that last episode, so we'll pass.
Matt's
on that one.
getting kicked off tonight, not me.
That's right. So, where do I go from here? Haney, you have another question? I guess it's my turn.
Yeah.
Maybe first, since you're on a roll, what are other factors? I know there's a lot of drugs. What are the other factors that can contribute to Tylenol toxicity other than Tylenol itself? And I'm going to say like clinically relevant, not the ones that you read in the book and you see there's like 30 drugs there. So what actually matters? When are you worried?
Sure. So there's some disease states that can impact it as well as some medications. So the things that we're kind of looking at is, as I've already talked about, how Tylenol is broken down. So anything that can impair the good breakdown or increase the bad breakdown that increases your toxic metabolite. So anything that can decrease your glucuronidation. So things like Gilbert's disease can do that, as well as medications like Bactrim, which are prescribed quite often for outpatients. So something to be cognizant of if a patient's coming in recently treated with a UTI or some type of cellulitis with Bactrim. and is presenting with, what looks like acetaminophen toxicity, this could increase it. Other medications that we might see that, patients are on would be like phenytoin, or phenobarbital, which are inducers of the 2E1 system. So because we are inducing that system, we're going to be increasing how fast the liver is breaking down the Tylenol into the toxic metabolite, right? And phenobarb actually becomes very important for us in the ER as well as in the ICU, because a lot of these patients, unfortunately, do have a chronic history of alcoholism and will experience alcohol withdrawal. And we use a lot of phenobarb for our alcohol withdrawal patients. So this might be one of those times, or I'm going to say is one of those times, where it would be contraindicated to use phenobarbital if they're presenting with acute Tylenol toxicity, because that's going to actually worsen it and worsen their acute liver failure. So you'd have to stick with your benzos. And then obviously anything else that can, decrease your glutathione stores. So patients with, that chronically use acetaminophen, but other than that, you're looking at patients that have chronic liver disease or malnutrition for the most part.
Great.
Haney, I feel like we need a whiteboard on the side where there's like a pearl that's dropped. That's just like boom. And I thought that was awesome. Tylenol toxicity, alcohol withdrawal, avoid phenobarb. Such a smart point that probably is easily overlooked.
I just want to point out that this is what people are saying in the audience.
Hey, he's one of my pharmacists right there that I work with. So
clearly from the naproxen industry. All right, all right, Matt. Let me, one of the things I remember from all my tox rotations and from emergency medicine is the stages of Tylenol toxicity. My first question is, could you review them for people who are taking their boards? And my second question is, does it really happen that way? Is that actually a thing, or is that just something that they make us memorize?
Yeah, that's a great question. Everybody loves the classic descriptions of, acetaminophen and some other poisonings as well. Like they talk classically about like iron, which is not what we're here to talk about today. But like with acetaminophen, I think they usually describe a 4-phase illness. Phase 1, usually asymptomatic. Phase 2, I think you're starting to get some right upper quadrant pain, some rise in your AST, ALT, maybe some renal injury as well. Stage 3, you're developing, more fulminant hepatic failure, lactic acidosis, coagulopathy, encephalopathy. And then stage 4, if you survive, prolonged recovery. I don't know that it really happens this way. And truthfully, with single massive ingestion of acetaminophen, acute encephalopathy, like requiring intubation and mechanical ventilation, has been reported. So, these are classic descriptions that are great to learn about, but I don't think patients really read textbooks very often. So nice to talk about. The other thing is that the nephrotoxicity can actually occur independently of liver toxicity, that you can accumulate NAPQ in the kidney. And so you could have acute kidney injury and show no signs of rise in your AST or ALT, or they're better markers of liver injury. So, yes, classic description, but take it with a grain of salt that, again, patients don't read textbooks.
I just want to say that for all those years of studying, now I know that all of it was for nothing. Thank you, Matt.
No, stay in school. Keep studying. You're doing great.
Right. Okay.
Haney, I thought you were going to say, like patients, I too don't read textbooks. So I got to jump in on this. Matt, tell me, this may be something I made up and it's not true, but I always remember being taught, because I know there's like in acute liver failure, I'm always most worried about, especially when their mental status is down, is cerebral edema. And I remember always being taught acute liver failure, ammonia over 200. That's when I'm concerned. Is that number made up? Is it like, when are you worried about cerebral edema in these patients?
Well, I'm not familiar with the hyperammonemia marker, but when you look at kind of the criteria for like urgent or emergent referral to a liver transplant center, I usually rely on the King's College criteria, which was looked at for patients specifically with acetaminophen overdose, if I recall correctly. And what they found was that the best indicator, or maybe the worst indicator of needing orthotopic liver transplant was grade 3 or grade 4 encephalopathy. And that's a clinical assessment. That's not based on a lab marker. So I think the hyperammonemia is really interesting, and I'd love to, again, after we warm up a little bit more, talk about why patients can get hyperammonemia, because I don't think it's just, I think there are multiple factors, including oxoprolinuric acidemia, that can contribute to the hyperammonemia, which will make encephalopathy worse and predispose to cerebral edema. But again, I think this is the King's College criteria does have laboratory parameters in there, but the encephalopathy was just a clinical diagnosis.
Great. Yeah, I think I just remember the elevated ammonia because we get patients all the time with cirrhosis that have
Yeah,
hepatic encephalopathy, and their ammonias are through the roof. And the teaching
yeah,
has always been, if you're chronic, liver failure, if you're cirrhotic, you can't get the cerebral edema that an acute liver failure can. And along with that hyperammonemia, I always remember if the AST ALT, if your transaminitis is less than 1,000, you're probably not going to be in that concern for cerebral edema. And once again, that those are probably all made up, but those were like the markers I remember going through my fellowship.
yeah. I mean, I think the other issue is it also depends on where you're catching the patient in their syndrome, in their
Mm.
toxicity, right? Because AST ALT can be resolving, and your ammonia can continue to climb, or your encephalopathy continue to get worse, right? That's just kind of your liver crapping out. Um, and so resolution of AST and ALT shouldn't be reassuring necessarily for those patients. And that's why I think the encephalopathy as a clinical diagnosis is going to be helpful, in that situation. Does that kind of make
Yeah,
sense?
no, that was perfect. Yeah, yep. I should forget everything I've learned, but no, that was helpful. Uh, sorry, Haney, I've been hogging it. What do you got?
Well, me, I'm kind of a little bit selfish, and I want to know if someone comes in with a significant ingestion, which patients need to come to the ICU and which patients could be safely monitored on the floor. If we're talking about, waiting 4 days for some of these things to precipitate,
Yeah.
with beds being a precious resource, who do we make the decision that this person needs to come and stay in the ICU, and who could we just put on the floor and then bring back if they get sick?
I think it's a good question. I think it partly depends on where you are, right? I think, and it depends on kind of the comfort level of the team on the floor that's taking care of the patient. I think in some small community hospitals, there's just not a lot of comfort with taking care of overdose patients on the floor. Whereas in, maybe a bigger tertiary care center, there's going to be a lot more familiarity with it. And a patient who's, got normal vital signs, if they've gotten if they're getting an acetylcysteine and they get their load in the emergency department and they don't have anaphylactoid or anaphylactic reaction, the likelihood of developing an adverse reaction on the floor with the ongoing infusion is very, very low. And those patients don't need to go to the ICU. I think the harder question that kind of goes along with your question, Haney, is who needs emergent referral to a liver transplant center right from the emergency department? And if you're working in an ER that is not associated with a transplant center, should that patient even go to the ICU, or should we just be mobilizing resources to get that patient out? Because if you've ever like tried to do, emergent organ transplant, it takes a lot of work. And delaying that level of care by putting a patient in the ICU when they're really sick, actually, I think puts the patient at risk. And maybe, I almost wonder if you're really thinking that a patient is sick enough to need an ICU level care, maybe we should also be thinking about transfer out to a transplant center.
Gotcha. So then, if what you're thinking is, or what you're saying is, someone comes in with a significant ingestion, they're going to be staying in the hospital, and they look well. Why waste the time of keeping them waiting for something to happen? Refer them out to a tertiary care center where they have easier access. They may go to a step down unit bed over there, but at least they have access to the ICU docs and transplant capabilities.
I think that's reasonable, but I also, by the same token, I think a patient who comes in early after their ingestion and is asymptomatic and can start N-acetylcysteine in the emergency department, get the first part of the infusion, and they've got normal vital signs, they've got a really high acetaminophen level, but their renal function's normal, their liver function's normal, they're not coagulopathic. They can stay there because the N-acetylcysteine should be protective from progression to fulminant hepatic failure. But if they come in almost like the patient that you presented in the beginning, Adam, and they're already encephalopathic and they're showing signs of liver failure, like that's a patient who may need to be referred to a transplant center rather than going to the ICU, even at a tertiary care facility, because they're going to get worse, and the N-acetylcysteine is probably going to be less effective at preventing progression to worse, more severe illness.
And that makes perfect sense. And I promise you, I didn't plan this comment from our good friend Randy, but this is the question that came up. So let's ask that question since we're on the topic. I have somebody that comes in with a significant ingestion. I have the ability, whether I'm in a small hospital or a large tertiary care center, to start N-acetylcysteine. How long do I have before I could confidently know that this person got their loading dose and they're likely going to be okay? That could be for either.
Usually 8 hours, and some would say up to 12 after the ingestion. It's not 100% because nothing's 100%, but generally speaking, if N-acetylcysteine is started within 8 hours of the ingestion, should be 99% preventative for progressing to fulminant hepatic failure.
That's great. Firth, do you have anything to add to that?
No, 100%. Within 8 hours, there's basically you're low risk for any type of serious hepatotoxicity or death or needing a transplant. So I 100% agree with that for the most part. Now, obviously, things get difficult when you are dealing with different formulations of acetaminophen that they took and things like that. But yeah, within 8 hours.
Could you elaborate on that before I'm hogging up the mic? That's my last question.
Yeah, sure. So, I'm sure everybody's heard of the Rumac-Matthew nomogram that is used for, treatment of acetaminophen overdose. Specifically, it takes into consideration the acetaminophen level as well as how long it's been since the overdose, and basically doesn't even recommend treatment within the first 4 hours of the overdose, no matter what the level is, which I kind of think is absurd. I don't usually use the Rumac-Matthew nomogram. Don't tell anybody. Because of that reason. Also, it's not very effective in patients that have overdosed over 24 hours ago. So your chronic ingestions, or if they come in late, this nomogram is ineffective. It's also not going to help if, like, for example, our patient case, he took it, his Tylenol with NyQuil, which has either diphenhydramine or doxylamine, some type of anti-cholinergic / antihistamine. As well as Percocet, which has an opiate. These things are going to slow gastric motility down. And in doing so, you might have an extended period of time in which the patient is experiencing toxicity as it is getting absorbed slower. So for me, if someone comes in and I have any evidence of Tylenol overdose, or they tell me they had Tylenol overdose, I'm starting NAC immediately.
Got it.
So then let me ask, when do you stop NAC?
Well, that's actually a debate, I would say. I think that a lot of the algorithms say that 21 hours are sufficient. Some say that we no longer need the loading dose. There's been a large study, multi-centered study, looking at removing the loading dose to remove the very rare side effect of non-IgE mediated anaphylaxis from injection site type reactions that's been as effective. And then sometimes, I'm sure Matt can answer this question a lot better than I can. You call your toxicologist if, the IR is still elevated, if the patient still has hyperbilirubinemia or elevated, Tylenol levels, they're going to continue that, the last bag, 3 to 5 days, depending on what it is that they need to accomplish.
Yeah, and I think one, I will say I am a big fan of the Rumac-Matthew nomogram, but I agree with Firth. We have to be very aware of the pitfalls, right? So it's predicated on a single ingestion at a known time, up to 24 hours out after the ingestion, right? And it doesn't predict well, let me take a step back. So I like it, but again, you have to be aware of the potential pitfalls. Probably doesn't apply to chronic ingestions because we don't know where the clock starts. Is it at the first dose or is it the most recent dose? In terms of the duration of treatment with N-acetylcysteine, for there have been a lot of kind of permutations over time. And, when we went to the IV formulation, marketed under the brand name of Acetadote, yeah, it was the 21-hour standard protocol. But if they had ongoing detectable acetaminophen levels, you need to continue that last bag of the treatment because, as Firth said in the beginning, it's not the acetaminophen that causes the problem. Ultimately, it's NAPQI, that toxic metabolite that's going to cause liver injury. And you only have NAPQI when you have detectable acetaminophen, right? Once the acetaminophen's gone, you can't generate any more NAPQI. So, but also to the point of like a massive ingestion, there are some patients who are actually doubling the loading dose and doubling the second part of the protocol because they have so much acetaminophen in them, they're going to generate all the more toxic metabolite and they need that much more protection. And so there may be patients in whom you can eliminate the loading dose, but there are some patients who are actually going to need double. So, we have to keep in mind single massive ingestions gets to be a bit tricky, and there are some other kind of nuanced treatments that may go along with that.
So can I ask, can you overdose on NAC? Is there
You
ever too
can.
much?
Yeah, there's a case report in the literature of somebody who actually ordered it. So rather than ordering it, so the standard 21-hour protocol is like 150 milligram per kilogram loading dose over an hour, then 50 milligrams per kilogram given over 4 hours, and then 100 milligrams per kilogram given over the next 16 hours, right? And what happened was the person actually ordered it, the 4-hour protocol, as 50 milligrams per kilogram per hour, and then the third bag of the 100 milligrams per kilogram per hour rather than over 16 hours. So they got massive amounts of N-acetylcysteine. They developed cerebral edema and died. So it's really hard to do, but it has been reported in the literature.
Would
The
you
other
say,
thing
Matt?
that
I'm
people,
sorry. I'm sorry to interrupt you. Would you say that would be more from the NAC itself, or possibly that huge dextrose load that NAC has to be mixed in since it can't be in saline that caused maybe hyponatremia that led to cerebral edema?
That's a good question. I don't remember the details of the case report and if they got into that, but my recollection is they attributed it to the N-acetylcysteine itself.
So
But again,
Interesting.
this is rare. And the other thing to keep in mind is that N-acetylcysteine does cause an elevation in the INR. So using INR alone as a decision to stop N-acetylcysteine is not your best choice. So you just have to be aware of that.
You were going to say something, Adam?
it was a joke about Randy that I've now decided it's inappropriate, so I'm no longer going to say it.
That's fair. I have a question for Matt. How long after your training did they name the normogram for you? All right, sorry. Seriously,
That was actually the entire
Yeah.
reason we made this episode, was
it was
just for that one joke.
sound effect.
Awesome.
Folks, good night. All right.
Nobody's naming anything after me.
So this is a question that I always have, with how good N-acetylcysteine is for preventing fulminant liver failure. Should we be giving it to any person that presents with any type of liver failure at any point? So let's say someone presents, and I'm just going to throw this out there. Let's say their cause is known, or let's say it's not known. Would it be beneficial to start that person on N-acetylcysteine to prevent that person from progressing to liver failure?
I don't know, to be honest. I think that's what we're going to touch on in the second portion of this podcast. But it's difficult to say. I mean, it's other than what Matt just described to me, as a potential side effect or an overdose from it, which I hadn't heard before. NAC is relatively, I hate to say the word benign, but relatively a safe medication to where if you're concerned with an acute liver failure, it's kind of like a why not scenario. But that's a difficult question. I don't know if I would pull the trigger on anybody if I don't know.
Yeah, I agree with you, Firth. I think, there's really limited downside to it. There are conflicting studies in the literature, and I think even conflicting meta-analyses about the utility for N-acetylcysteine for non-acetaminophen-induced liver injury. But if you're suspicious, I think there's very little downside. I mean, I think it's a good free radical scavenger, um, and can have some protective effects for the liver. At Cooper, we have a protocol for non-acetaminophen-induced liver injury and acetylcysteine administration. It looks almost exactly the same as acetaminophen-induced liver injury and acetylcysteine administration, but it is broken out separately. It was tried for things like Amanita phalloides ingestion, probably didn't work that well, and some other things. But there are some meta-analyses out there that show some signal towards benefit. But again, very little downside.
Matt, that's just a fancy way to say mushrooms, right?
Yes.
Yeah.
Yes.
Yeah.
Okay.
So
This is so exciting, by the way. I'm really so happy to be here talking with you guys about it. I'm totally jazzed up. I just want to say, and I'm working overnight tonight, so this is going to help me coast through my overnight shift tonight. So I just
Good.
want to tell you how grateful I am for this opportunity.
I'm gonna have nightmares of Amanita phalloides tonight.
Well, hang on. We're gonna nerd out to that in just a little bit. But and this might be a kind of silly question, but I want to put it out there for the learners that are watching. What about people who come in with shock liver from hypoperfusion, elevated AST/ALT? Any benefit at all for giving N-acetylcysteine for those patients who present?
I personally have only read one study and a couple case reports, and most of them are septic shock using NAC. And they do try to report that there is a benefit using NAC. NAC has the ability as an antioxidant, as a vasodilator to help increase perfusion to the liver. I just can't come to the conclusion that it's the NAC that helped improve the patient. It seems more that the patient got improved because you targeted the cause of the shock, which was septic shock. They started antibiotics, they gave fluids, and did all these other things, and the liver functions improved. So I'm not a believer at this time, based off of the current literature and evidence, of using N-acetylcysteine for an ischemic liver injury secondary to shock liver.
Yeah, Matt, it sounds like you feel the same. And listen,
Yeah.
we trust you guys. You guys seem to have a knack for this stuff.
That was the other joke you were waiting for. Nice.
There we go. All right, Adam, should we move on?
Yeah, can I a little bit more about Tylenol? How about, I've seen case reports about the use of Fomepizole and Tylenol overdose. Is there a role there?
Yeah.
And the other one I want to know about is, when do you pull the trigger for hemodialysis, and is there a role? Those are the two other adjuncts.
So I can talk about Fomepizole. So I personally have never used it in a Tylenol overdose case, but I'll kind of explain how it works. So without going back into the pathophys, we talked about the 2E1 pathway, and inducing that metabolism increases the toxic metabolite from Tylenol. So what Fomepizole does is it actually inhibits 2E1 in the liver. So it doesn't allow the liver to break the Tylenol down into that toxic metabolite. So theoretically, it can be used adjunctively to NAC to possibly help certain patients that have Tylenol overdose, maybe for those mass ingestions. Like I said, I've personally never used it. It's a very academic thing, and I know there are some case reports using it. But it's something that I think can be utilized in those patients that are not responding to NAC as quickly as we would like them to. Now, let's leave it up to Matt to see if he has any experience using it.
I have not, and this I think is pretty recently described. I had one case actually where I, in hindsight, wish I had given it, but I didn't think to at the time. But I think for a sick patient who's already showing signs of like acidemia and organ dysfunction, we should consider giving Fomepizole. Yeah.
How about
As adjunctive to
hemodialysis?
N-acetylcysteine. Yeah, and hemodialysis is super cool, right? Like, and we had our index case at Cooper a bunch of years ago, and the patient did really well. And for we have an expected elimination half-life of acetaminophen of about 2 to 3 hours, right? And in the setting of a massive acetaminophen ingestion, if your metabolic pathway is not working, you're just going to hold on to your acetaminophen for longer. You're going to have more liver injury. And hemodialysis is really good at getting rid of acetaminophen. It clears it out very easily. And so for massive ingestions, I think it is something that we need to consider, because again, for those patients, we don't know how much N-acetylcysteine to give them. The protocol is based on a lower overdose. It's not based on massive ingestion, and we can try doubling the N-acetylcysteine and giving them a whole bunch, but we don't really know the answer to that. And we can't measure NAPQI concentrations, right? It's not something we can clinically do. So I think in those situations, we really need to consider hemodialysis. And I think that the XTRIP Collaborative has some recommendations on when to consider hemodialysis. And it's really effective. You do have to adjust your N-acetylcysteine infusion when you're putting the patients on hemodialysis, but you just double the rate of infusion, I'm pretty sure, and patients do fine. But yeah, in massive ingestion, something definitely to consider.
This came up in the comments. So first of all, is that true? And then second of all, which smells worse, fomepizole or, I guess that was fomepizole, or oral N-acetylcysteine?
I thought N-acetylcysteine, it's a sulfa-based drug. It smells terrible.
It smells
like eggs.
Rotten eggs.
Yeah.
That's why no one gets it orally anymore, even though it works just as well as IV.
Yeah.
There you go. All right.
Was that your question?
It can be. All right. Well, let's move on now, and let's talk about liver failure in general. So, unless anyone has questions, please drop them in the comments. If you have any questions on acetaminophen overdose or N-acetylcysteine, nothing on the Cori cycle, but please ask your questions, and don't forget to like and subscribe to the channel. This is the only way you get notified when we go live. So we're going to move on now, and let's just talk about liver failure in general. And first of all, I think a good thing to do is just define what acute liver failure is for everyone out there. Who wants to take that?
I mean, basically, we kind of talked about it a little bit earlier, but it's coagulopathy. So INR greater than 1.5. You can look at platelets as well, usually less than 50,000. Some might be a little bit more conservative and use less than 150,000. And then encephalopathy. So different grades of encephalopathy are going to determine whether someone's in acute liver failure, which I think is why Matt kind of, rebutted Adam as far as the, AST levels, ALT levels, and things like that, because it's a clinical diagnosis in addition to coagulopathy.
Great. Matt, anything else that you use in your determination?
No, that's it for me. I know some I've encountered some, intensivists and other physicians, maybe hepatologists, who will check synthetic factors in the liver, but that's not really something that turns around very quickly. So yeah, I'm usually relying on what Firth said.
And I think they can't have any type of history of cirrhosis, so no history of chronic liver failure. And it can't be more than like 26 weeks or something like that, because I think that's what the cutoff is for chronic liver failure.
Gotcha. Does anyone want to take this question? Coagulopathy of acute liver failure from our friend Randy. How's it different than DIC?
Have at it, Matt.
I don't know.
Usually the fibrinogen's not as low. I think I know that.
What's that?
It's a slippery slope, and in fact, sometimes I ask the question, does it matter? Right. So, and it probably doesn't matter. So acute liver failure very frequently looks extremely similar to DIC, just like those who are in acute liver failure very frequently have kind of subacute distributive shock, right, Haney, that just never seems to go away. They have vasoplegic vessels. That's some of the underlying pathophys behind cirrhosis and liver failure. So I don't know if it matters. I mean, I usually treat it the same way. In terms of fibrinogen goals, it depends on if they're bleeding or not bleeding. I think a question kind of stemming from that is, when would you use vitamin K in the treatment of acute liver failure? Is there a need? Do you ever do it? If the INR is a certain level, do you start getting worried? Does it work? I think all those things are probably worth discussing.
I think I personally don't use it to treat anything. I would say that I use it more as a diagnostic tool to determine how bad the liver failure is. So if a patient's liver failure is pretty bad, they're not going to be able to utilize the vitamin K in order to produce clotting factors. So I'm not going to see an INR response. If I see a response, I can see that the liver might be responding to what it is that we're doing, and it's actually in the healing process. But I don't use it to actually treat anything for the most part, because most of these patients, even though their INRs are elevated, are actually more inclined to clot and are at risk for portal vein thrombosis.
So when you give it, how do you order it? How do you said you give it?
10 milligrams IV. 10 milligrams
always IV. Never PO, never
always
sub-Q,
IV.
always IV.
Correct.
Matt, you were going to say something?
Yeah, I was just going to say, I feel like I see it given frequently, but I don't usually recommend it. But
it doesn't do anything for us. We're not going to change our treatment based off of giving vitamin K.
Yeah.
Okay. What should we talk about now? So we talked about acute liver failure, kind of the definition. I always think it's so fascinating that it has to do with kind of evidence of decreased synthetic function, right? With seen as the coagulopathy, decreased clearance and functionality in terms of the confusion, but it's never an AST and ALT transaminitis. I always think that's interesting and kind of hard to swallow, right? Like they come in confused with a coagulopathy, and that's the definition. I think that's interesting. What do we think about if it's not Tylenol, like in the cases being presented to you, Matt, as a toxicologist, what's your differential that you're running through in terms of what's driving this process?
yeah, just in the setting of fulminant hepatic failure.
Yeah.
I mean, there are always, weird things like, I mentioned Amanita phalloides, one of the, poisonous mushrooms. It depends also on the clinical presentation, right? Are they showing signs of sepsis, septic shock, and is it just, shock liver? I always try to keep acetaminophen on the differential. I'm trying to think. There are a whole bunch of other things. I think Wilson's disease is something that we often kind of go looking for. And then what else do I keep on there? I feel like those are some of the big ones. I think if you went to Goldfrank's textbook of toxicology and you just went to the, liver chapter, I'm sure there's like a table that takes up the entire page of hepatotoxins that I'm sorry, I can't. I would love to be able to recite off the top of my head. I'm just not that good. Sorry, guys. But common things being common. I think septic shock, shock liver, acetaminophen are going to be the big things on my differential. Decompensated viral hepatitis or acute on chronic hepatitis, viral hepatitis infection, things like that.
Yeah, I mean I think I was always taught ACLT over 1,000. There are three main causes, right? It's shock liver, acute hepatitis, and what's the third one? Tylenol, of course. Tylenol, yeah. And those are the main. But I always think like the other things, of course. I always think like there's autoimmune hepatitis that can cause acute liver failure. There's Budd-Chiari, right? And then there's some really weird, even less common things.
HLH.
Yep, HLH.
Yeah. So sexy to say HLH because when nothing fits, you could just say that, and people are like, "Whoa, that person really."
Order a ferritin. That's all you got to do.
That's right. Haney, I thought what we would do, I think we've talked about almost everything. We talked about NAC, we talked about vitamin K. How about steroids in acute liver failure? What's the role of steroids? I think there's a couple indications.
So There's really only two that really come to mind for me, and one I almost don't classify as acute liver failure. So the most common one that we see it used in is acute alcoholic hepatitis, and most of these patients, because most evidence shows that an acute binge of alcohol does not cause acute alcoholic hepatitis. Usually, it's your chronic alcoholic that has some type of underlying liver disease that pushes themselves over the edge. It goes into acute alcoholic hepatitis. They, will have a 28-day mortality benefit by being placed on steroids, specifically prednisolone. We calculate the Maddrey score and come up, and determine whether or not they'd be a candidate for it. And then the other one would be autoimmune hepatitis. Obviously, if the immune system is responsible for the acute liver failure, suppressing that immune system with steroids can be beneficial. So they're the kind of the two that I think of. I don't really use it in any other scenarios.
So let me ask you this, and you mentioned it before, but this is something that often gets forgotten. When your INR is high in somebody who is in liver failure, it does not mean that they're hypocoagulable. In fact, sometimes it's hypercoagulable when they start to lose function of protein C and protein S. Yes, I studied in school.
Yes.
But this question will be asked of you, or maybe more further on rounds, like when do you decide to do DVT prophylaxis on that person? Or if the person has a portal vein thrombosis, but their INR is, let's just say 3.1, what's your advice on that? So
portal vein thrombosis, they're getting anticoagulation.
Okay.
It doesn't matter what the INR is. We can give the vitamin K to see if we can reverse that, but it doesn't matter. They're, like you mentioned, it's a synthetic dysfunction. They are still hypercoagulable. Therefore, I'm going to fully anticoagulate them to make sure that they don't, have any worsening of their portal vein thrombosis. And these patients, if they don't have portal vein thrombosis, even with an elevated INR, I'm still putting them on DVT prophylaxis because they are at risk for DVTs.
And then what are you following? What are you following in the case of the person who has portal vein thrombosis, if you're using?
So if you have access to it, 10A levels would be great. In Inspira, their send-outs for us, unfortunately, we're following more clinical signs and symptoms of bleeding to where we would stop it. But 10A levels would be great for the most part.
Fantastic.
Otherwise, PTT?
PTT can be utilized, but once again, it's probably going to be skewed just like the INR is going to be skewed because of the synthetic liver dysfunction. Because PT is what we use when we calculate the Maddrey score.
Great. So my last one is stress ulcer prophylaxis. Like we've all seen that cirrhotic who comes in with hepatic encephalopathy and then develops GI bleed from a big peptic ulcer. So when do you start the PEP? Which patients qualify?
Yes, the definition of coagulopathy, which is an indication for GI prophylaxis. So if the patient has an INR greater than 1.5, or they have platelets less than 50,000, and neither one of those are associated with an antiplatelet drug or an anticoagulant, they should be placed on GI prophylaxis because they are at risk for spontaneous GI bleed, which does sound counterintuitive to what I just said in regards to there being, hypercoagulable, but that is the guideline recommendations.
I have a question for you, Firth. These guys over the weekend who are fishermen, they got caught stuffing lead weights inside these fish that they caught to cheat. As a fisherman, and Matt, forgive me if you're a fisherman, I didn't know that about you, but I know Firth is. How can you stick a lead weight inside a fish without anyone knowing? Why do they have to cut it open?
I've never done it, so I don't know.
He just.
So I'm an honest fisherman. I definitely would never stuff my fish with lead weights, but I imagine just like a fish can swallow something whole, you put the lead in through the mouth, it goes straight down into the belly.
They also put fillets inside the fish. They put fillet. They stuffed lead weights and then fillets inside the fish, and when they opened it up, they crazy.
Definitely too much thought put into that form of cheating. Let's put it that way.
They're disqualified. That's all I know from further fishing events. I'm not a fisherman, but I was fascinated by the virality of these people who got caught for cheating on bass, which I didn't even know was the thing. I didn't know you could cheat at fishing, but apparently you can. Well, on that note, gentlemen, Adam, any other questions that are burning inside of you? Any about fishing or acetaminophen? Or
So that's why. So yeah, I have a question about fishing. Is that why when you have a competition, a fishing, they have to be alive? But like, what
Yes.
keeps you from like going to the local Wegmans and grabbing some fish?
They 100% have to be alive. And
Ah.
usually the judges that are either weighing or measuring your fish are there in front of you when you bring them in. So you can't pull them out of your cooler.
Matt, I feel
Nice.
like we're asking Firth a lot of questions about fish. Let me ask you a question about fish. What is the best sushi restaurant in Philadelphia? Matt is my go-to for whenever I have
Oh,
a question about food.
that's a great question. It depends, again, Haney, it depends on what kind of sushi you want to eat. Do you like the chef's tasting menu, the omakase?
Yeah.
Yeah,
Let's say yes.
there's a place in Queen Village called Royal Izakaya, I think is how you pronounce it, and they have a back room, which is a sushi tasting room. And that is really fantastic. And it's a chef's menu. So you sit at the sushi bar, you watch the chef prepare it, he puts it in front of you, you eat it, and it's delicious. There's another place, I think it's called Sakana, also in Queen Village, which is really, really good. It's also just an omakase chef's tasting place, and it's incredibly beautiful. There's a place up in New York City that is an omakase sushi restaurant that is the most expensive restaurant in the United States. I don't know what it's called. I've never been. I think it starts at $600 a person.
Wow.
For the chef's tasting menu. So, maybe someday, if I really take off as an influencer on social media, I'll be able to get there. But for now, I'm going to stick with stuff in Philly.
Follow-up
But
question.
if you want,
Go ahead.
yeah, go ahead.
No,
I think if you want just really good sushi, fat salmon is delicious. And out in Collingswood, there's been a place for a really long time I think it's called Sagami, and their sushi is fantastic.
I've been to Sagami. They are very good. But my follow-up question
Yeah.
is, let's say you just like to stuff your face with sushi like me. Do you judge me for going to an all-you-can-eat sushi place? Are you judging me?
No,
Okay, good.
this is a no judgment zone. Look, most of what I do is addiction medicine these days. It's all no judgment here, right? So,
Well, I love you, Matt.
Haney, you definitely won't need any lactulose after all that sushi.
Oh, hang on. Got you too. All right, good job. Gentlemen, I can't tell you how much I appreciate you coming back on the program, and I know everyone here appreciates you too. Show your love with the likes. We have a lot of people watching tonight, so thank you both for being here. And I'm going to say it because I mean it. I want to get you guys back on to talk about something else, sometime in the future.
cool.
Let's do it.
That would be awesome. Thanks.
For sure. Adam, any
Pills
closing
That Kill Part 3.
Anything else before we let
No.
this go, Adam?
No, that was really great. The episode was perfect. It kind of took it's on its own life, and it's just so easy with you guys. So I know you were getting a little emotional back there, Matt, but we really do appreciate you guys coming on. I think it's awesome. I love the atmosphere. It's really great stuff, and I learn something every single time I do this. So appreciate it.
Yeah.
Next time Matt gets to talk about hyperammonemia, I want to hear it.
Yes. It's one of my faves. That and the
So I
osmolar
can-
gap. Can we do that?
So I can
Yeah.
bash
Oh.
Rifaximin.
What did you say? What did you say, Matt? You want to talk about what?
The osmolar gap and why you should never do it.
I think an alcohol
Yes. At
least for-
ingestion,
Yes.
an alcohol ingestion episode would be excellent.
Little propylene glycol.
All right, now
Yeah.
I'm definitely
There we
kicking both you guys off. All right, thanks for coming.
Ah,
See you soon.
Thanks, guys.
Oh man,
thank you.
I couldn't let that propylene glycol and
Yeah,
whatever they're
seriously,
talking about too far. You know what I mean? I'm
Seriously.
not that smart, and
outrageous.
frankly, I'm hungry. I'm hangry right now, so I can't do it. But honestly, Adam, we knew that was going to be a great episode, and those two lived up to it. Such smart people. I'm glad we had them on. So-
I wonder where Cooper ranks in the sushi rankings.
The cafeteria.
Yeah.
Well, I mean, we can't. I mean, we're not going to bring Matt back on. He's already off. But I'll tell you this. I will tell you this. I was here this is my 6th year at Cooper, and it took me 4 years before I even looked at the sushi because I was like, you don't get sushi from a cafeteria. And on a score of 10, I'm going to give it a solid 4. And when I'm really hungry, it's a 6.
Yeah. No, I agree. I like it. I enjoy it.
Yeah. It's not good, but it's not bad. Oh, man. So, Adam, it was always good to hang out with you. What do we have in store next time? Do we have a sense of what's coming next?
Yeah, I think 2 weeks from now, the plan, which we all know can change, is to talk about acute pulmonary embolism. And I'm pretty excited because we have an interventional cardiologist who loves catheter-directed therapy.
Uh-huh.
We have an intensivist who loves to call that cardiologist. And I think we should talk about both sides. And I'm already thinking about a million questions I want to ask them. So I'm excited.
I think what we should do, and we've talked about this, but I think we should get guests that disagree more. I mean, collegially and very nicely, but I think this is going to be the first episode where there's a little bit of a friction, a little bit of a clash between the guests, and I'm loving it. I'm looking forward to it.
More so than the disagreements of how to use a nomogram, because it got a little heated tonight.
Oh, as far as toxicology goes, it was a throwdown. I mean, it was pretty close to fists. But but I think it would be good to see, because I think the way you read the literature on PEs could be interpreted very, very differently. So that's going to be a really good episode. And you know what? If they're collegial, we're going to make sure we throw a little fire, fuel on the fire. Make sure they get a little bit snippy. It'll be great. And Nicole, on the final thought, says the sushi is pretty okay. So that ranks right up there. It really is dependent on how hungry you are, on how delicious it is.
Good night.
It was good to see you. We will see you soon, folks. Stay tuned for more. And like I said, if you want to know when we're going live again, subscribe to the channel. But for now, Adam and Haney, we're out.